Hello guys, welcome back to my channel, Man at Anat. In the previous part 1 of the brachial plexus, we learned about what are the branches of the brachial plexus, what is brachial plexus, what nerves arise from the brachial plexus. Okay, we learned about posterior cord, medial cord, lateral cord, and their nerve roots and the nerves that are arising from this. Okay, but we didn't talk about the clinical correlation that was associated with the brachial plexus. And when question comes from brachial plexus, they might not ask you to draw or label, but they will ask you about the clinical correlation of the brachial plexus. And if your viva in university examination or your part ending examinations or your preliminary examination, if your viva of the upper limb is going well, then trust me, they are gonna ask you about the clinical correlation of the brachial plexus. Okay, before starting off with the brachial plexus's clinical correlation, let me just quickly give you a revision of just one point, that was UBS point. Okay, because it is gonna help you in the upcoming points. Okay, what was UBS point? UBS point, it is a point in the upper trunk. Okay, it is a point in upper trunk where 6 nerves meet. Okay, now what were these 6 nerves? Okay, it was like something, if you want to give off a schematic diagram, it was something like this. Okay, this is your UBS point. Okay, what this is C5, this is C6. We know that C5 and C6, they merge to give us the upper trunk. Okay, and then upper trunk divides to give us the anterior division and the posterior division. Okay, and this is your suprascapular nerve, and this is your nerve to subclavius. Okay, so this is your UBS point. For just right now, just remember that this is UBS point. Okay, UBS point, the injury in the UBS point causes UBS palsy or the UBS paralysis. Okay, which we are going to further study. Okay, but right now just remember this. Okay, in the clinical correlation, we are going to study about 3 topics, or the 3 clinical anatomies that is associated with this, that is UBS palsy, Klumpke's paralysis, or palsy, and Horner syndrome. Now some might argue that Horner syndrome is in head and neck portion, or it is in upper limb portion. We can study it in the brachial plexus because of the involvement of the T1 fibers that we are gonna see. Okay, what were the T1 fibers? This T1 fibers. Because of this T1 fibers, we are going to study the Horner syndrome here itself. Okay, before studying about the brachial plexus, one should understand this certain points. Okay, that we have studied about what roots. We have studied about C5, we have studied about C6, we have studied about C7, C8, and T1. Now these all nerve roots comprise the brachial plexus. And where was brachial plexus present? Brachial plexus is present from our shoulder to our fingers. Okay, it is present. The brachial plexus, the nerve plexus that it is making, it is controlling our movements at the shoulder joint, at the elbow joint, at the wrist joint, and all the movements that are occurring in our fingers. Okay, so it is controlling this movements. Okay, so we are going to talk about what movements are this gonna control. For example, if we talk about C5, it controls the abduction of shoulder. Once, if you just mug this thing up, or if you just understand and then mug this thing up, then trust me, UBS palsy or this Klumpke's paralysis will become easier for you. Okay, just for right now purposes, just try to just mug it up. Okay, so C5 controls the adduction. It controls adduction of shoulder joint. Okay, while C6 and C7 both controls the abduction. of shoulder joint. Okay, what is adduction? Moving of your shoulder towards your body. Okay, and what is abduction? What is adduction? Towards the body. What is abduction? Away from your body. Okay, as simple as that. Okay, now C5 and C6 both controls the flexion at elbow. Okay, C6 and C7 controls the extension at elbow. Okay, and lastly C8 and T1. Okay, they control our flexion at wrist and fingers. Okay, remember this one thing: whenever you think of C8 and T1, just think of this as one thing, that C8 and T1 is only going to control the movements at wrist and fingers. Okay, C8 and T1 is only present, it is only going to control the movements that are present in our wrist and fingers. Okay, now coming to the injuries, what we are going to study. Okay, supposedly think this is a man. Okay, not a very good person, but still, just our work just might be done with them. Okay, yes. Okay, suppose this person has some kind of injury, okay, or he suffers some kind of accident or something. In that injury, in that accident, if this angle between his head and angle between his upper limb is increased, if this angle is increased, then this is going to cause you a upper trunk injury. Okay, and this upper trunk injury, that is what we call, it is the Erb's palsy. Okay, and if there is certain injury in which the angle between your upper limb and your trunk is increasing, this is lower trunk injury, and this is going to cause you Klumpke's paralysis. Okay, so as simple as that, if the angle between your head and your upper limb is increased in any sort of accident, then it is going to cost you your upper trunk, and that is going to cause you the Erb's palsy. Okay, if the angle between your upper limb and your trunk is increased, then that is going to cause you lower trunk injury, and that is going to cause you the Klumpke's paralysis. Okay, now coming on to the Erb's palsy. Okay, Erb's palsy, I would say it is one of the most important clinical questions that is asked. Okay, it might come as your 6 marker clinical question. It may come as directly in your 10 marker question that give us the clinical correlations associated with the brachial plexus and draw and label brachial plexus. Okay, so it is important for you, and frankly it is a very easy topic too. Okay, so what I told you, that Erb's palsy, it is an injury of upper trunk of brachial plexus. Okay, upper trunk of the brachial plexus, and more precisely Erb's point. Okay, we just studied here that what is Erb's point. Yes, this is your Erb's point. Okay, now seeing like what are the nerves that are lost here. Okay, we can see that C5 is gone and C6 is gone. Okay, so from this, can we assume that the movements that were controlled by the C5 and the C6, they are also gone? Yes, as simple as that. If my adduction of shoulder was controlled by C5, okay, now if my C5 is gone, okay, then what is going to happen? Okay, my abduction will become more powerful. Okay, if one particular movement, just remember this one rule, if one particular movement of any joint is lost, okay, because of some paralysis or anything, okay, then the contrary movement or the opposite movement is gonna become more stronger. Okay, that is just gonna happen. Okay, so when we talk about the Erb's palsy, we have to think about this Erb's point and the root value, that was C5 and C6. Okay, so what are the now what we see in Erb's palsy? Yes, it is controlling our elbow joint and it is controlling our shoulder joint, but it is not controlling, or if it is not extending up to our wrist and our fingers. Okay, so whatever we are going to see in Erb's palsy, it is only associated with your shoulder and your elbow joint. Okay, don't go further than that. Okay, now starting with the Erb's palsy or Erb's point. Okay, now what could be the cause? We know the cause is the angle between your head and your upper limb has increased. That was what, because of which there is upper trunk injury and because of which there is Erb's palsy. But what could be the causes because of which this angle can increase? Okay, the causes could be fall from a height. You can that causes could include that you are falling from a height, and landing on your shoulder. Okay, something I would say like this. Okay, this, you are falling something like this. Okay, so here your angle is increased. Okay, so something like this. And it is also one of the common birth injuries. Okay, when sometimes there is some complicated delivery, then there could be traction of arm and hyperextension of neck. Okay, if something like this happens, okay, while during parturition process or during delivery, if there is hyperextension of the neck, what happens? Okay, we just saw that hyperextension of neck, in that scenario, the angle between your head and the angle between your upper limb is going to increase. Okay, the angle is increased. What is going to cost us then? It is going to cost us upper trunk. Okay, and if upper trunk is gone, then Erb's palsy, right? As simple as that. Now, what are the nerve roots that are associated? We know that it is going to cause an injury on the Erb's point. Now, what nerves root were gone? Okay, our C5 and our C6 are gone. Okay, so what are the nerve roots affected? C5 and C6. Okay, now the C5 and C6 gave us some nerves, gave us some branches. It gave us upper trunk. From upper trunk, it gave us lateral cord, and it also gave us medial cord. Okay, see here, where it is. See, okay. C5 gave us the C5 and C6 are a portion of lateral cord. They are a portion of the posterior cord. Sorry. Okay, so C5 and C6 are the portions of our lateral cord as well as of our posterior cord. Okay, so what nerves are going to be affected? This axillary nerve is going to be affected. This nerve, okay, this lower subscapular is going to be affected. This upper subscapular is going to be affected. This radial nerve is going to be affected. Okay, so these are the certain nerves that are going to be affected. You don't need to learn that, but you surely need to learn what muscles are going to be affected. Okay, what muscles are going to be affected by this injury? Okay, so the first muscle that is going to be affected by this injury, it is your deltoid. Now, what is the nerve supply of your deltoid? It is your axillary nerve. Okay, where is axillary nerve coming from? It is coming from your posterior cord. Okay, what are its root values? You can see here. Okay, C5, C6. Okay, so C5, C6 were gone, because of which axillary nerve is gone, and because of which deltoid is gone or deltoid is paralyzed. Okay, again Just like this, supraspinatus is also gone. Supraspinatus is also affected. Infraspinatus is also affected. Okay, then our biceps brachialis. Okay, and brachioradialis. Along with our supinator and extensor carpi radialis longus. Supinator and extensor carpi radialis longus. Now, why do you have to learn about the muscles that are affected by this injury? Okay, because the movement that were associated with these muscles, okay, like for example deltoid, what deltoid used to do for you, deltoid used to do abduction for you at the shoulder joint. Okay, deltoid used to do abduction for you at shoulder joint. Okay, but now as your deltoid is gone, this abduction is also gone. This abduction is now not possible at your shoulder joint. Now what will happen? Now if your abduction is absent, then the contrast movement, that is the adduction of shoulder joint, that will become more stronger. Okay, the adduction at the shoulder joint, that will become more stronger. Okay, once you lost your abduction. Okay, so this was about your Erb's palsy. Okay, now what are the typical features that you are going to see in a person? Like a patient walks into your clinic. Consider yourself that you are one of the biggest surgeons in India. Okay, you are a brachial plexus surgeon. Okay, and a patient walks in your clinic. He will not tell you that surgeon, I have destroyed my C5 and C6 nerve roots. My deltoid is affected. My supraspinatus is affected. My infraspinatus is affected. Okay, can you make a diagnosis based on this thing? No, you can. Patient is not gonna say you these things. You have to look at the patient. You have to see the symptoms. You have to see the signs, and then you are going to diagnose it. Okay. So, what is the typical characteristic feature that you are going to see in this particular injury? That is none other than typical feature. This is none other than policeman's tip hand, porter's tip hand, and it is your waiter's tip hand. One time what happened, when I was in first year, so I was going by Activa with my father. My father was sitting behind me. Okay, so we were like at something 30-40 speed. Okay, so when I was crossing this particular 4 crossroad, okay, you know this 4 crossroads. Okay, so I was watching this. So I was going from this to this particular direction, and suddenly I saw a person who was having this typical textbook diagram, typical textbook features of Erb's palsy. So like if I was going from left to right, on Activa he was going from right to left while walking. So I just twisted my neck and I just went to saw him. Like I just saw him and I was just ogling him. I was just staring at him, because of which me and my father crashed into an Activa, but thankfully we both were not injured because I was not speeding at that time. Okay, so but that I want to tell you, okay, if once you see medical science, in medical science you are going to see patients, and medical science is right across you. Okay, for example, if you study hypertension, if you study diabetes mellitus, you are going to see 4 patients in your own house only. Okay, so try to relate this with your real life world. Okay, just don't mug it up. Okay, try to see it in your world, try to see it in your wards if you are going to wards, and if not possible, then just Google the images. Okay, what kind of images, what kind of patient would be presented in my OPD if I am a surgeon. Okay, just do it. Okay, now what are the clinical features? Okay, what are the clinical features that are associated with this particular injury? Now what I told you that yes, your deltoid is gone because your axillary nerve is gone. Okay, your deltoid is gone. And what was deltoid's function? Deltoid's function was to abduct your arm. Okay, abduct your arm. Okay, abduction at the shoulder joint, that was your deltoid's particular function. Now that is gone. Okay, so what would happen? Adduction of arm will occur. Okay, adduction of arm will occur. Okay, your arm will stick to your trunk. Okay, second, your supraspinatus, your infraspinatus are also gone. Okay, now what were their work? Okay, your supraspinatus and your infraspinatus, they are also not working. Okay, now what were their function? Okay, they used to do the lateral rotation of your arm. Okay, at the shoulder joint. Now your lateral rotation is also gone. Okay, so what is going to happen? Your medial rotation of the arm is become stronger. Okay, so this will cause you medial rotation of arm. Third, it is your extension of elbow will occur. Why? Because at elbow, flexion is done by your biceps brachii. Now your biceps brachii is gone. Okay, so if your biceps brachii is gone, then what will happen? Extension of elbow will become stronger. Okay, biceps brachii not only does your flexion at elbow, it also helps in supination at the elbow joint. Okay, sometimes professor do ask you in their vivas that what are the functions of biceps brachii. So typically students just only focus on this part, that it does flexion at the elbow joint. It does that, but not only flexion at elbow joint, it also does the supination at elbow joint. Okay, so if supination is gone because your biceps brachii is gone, then what will happen? Your pronation will become more stronger. Okay, this is going to happen. Okay, so these are all your muscular effects, that what is going to happen to your muscles. These are all your motor effects. Now what is going to happen to your sensory effect? Okay, because there will be loss of sensation. Okay, so what is the sensory effect? Sensory effect will be in your arm, on the outer aspect. Okay, on your arm, on the outer aspect, the sensory innervation would be affected. Why it would be affected? Because of involvement of the C6. Okay, the C6 spinal nerve supplies sensory innervation to the outer aspect of your arm. Now as we know, in Erb's palsy, your C6 is gone. As your C6 is gone, so sensory innervation on your outer aspect of the arm is going to be affected. Okay, there is this one thing that might be asked in your MCQ exam, that they will give you options. Okay, what does not happen in Erb's palsy? Okay, that first option will be motor loss is not affected, motor is not affected, motor innervation is not affected, sensory innervation is not affected, autonomic innervation is not affected, and all are affected. Okay, so you have to say no. Okay, no, autonomic innervations are not affected. Okay, this is the right answer. Okay, no autonomic changes are seen in this. Erb's palsy, and if they do not say address this as Erb's palsy, they might say you as the upper trunk injury. Okay, so even if they say that write a case on upper trunk injury, then they are just referring to the Erb's palsy. Okay, don't try to overcomplicate things. Okay, second, this is your Klumpke's paralysis. Okay, and this is your lower trunk injury. Okay, now I told you just initially, okay, why does this lower trunk injury occurs? It occurs because of increase in angle between your trunk and your head. Okay, this is going to cause your lower trunk. Okay, but why does it happen? Okay, in what conditions there's our lower brachial plexus is injured? Okay, so the causes could be sudden pull of your arm, sudden upward pull of your arm. Okay, sorry. Okay, now when does generally this thing happen? Sudden upward pull of arm. Okay, consider like you are falling from sky. Okay, you are falling from sky and you are falling in a valley, you are falling from sky. Okay, now you see that there is one branch just below me. Okay, so what I'm just gonna do is I'm just gonna hold off to this branch. Okay, so what will happen? I will hold off to that branch. Okay, but I am a very healthy person. I belong to a very rich family. Okay, my weight is 100 kgs. So what would happen in that condition? Consider this is your branch. Okay, so this you are holding, let's make it clearly. This, in this condition there is there is increase in angle. Okay, this could be the condition associated with it. Or unless sometimes even we also say that when a mother and a child is crossing the road. Okay, mother and a child, they are crossing the road and the bus is just gonna hit the particular kid. Okay, now what happens is the kid, if it is 3 years old or 4 years old, it does not, it's his height or her height do not come to the level of his mother. Okay, so what mother would do if she just withdraws, like if she just snatches the baby, okay, by her arm. Okay, then in that condition also this lower trunk injury could occur. Okay, so in particular scenario when there is sudden upward pull of your arm, okay, in that conditions lower trunk injury occurs or the Klumpke's paralysis occur. It is also an birth injury. Okay, even in cases of birth injury it could be occur. Okay, when there is arm pulling, okay, which is just which I told you. Okay, sudden arm pulling of the sudden upward arm pulling. Okay, which may also be done during the at the time of birth. Okay, sudden arm pulling. Okay, so this might happen. Okay, now second thing is, what are the nerve root affected? So we just studied that it is C8 and T1. Okay, what we just understood right now, okay, what does C8 and T1 innervate, or what are the functions that are, what are the movements that are done because of the C8 and T1 nerves? Okay, these are flexion at your wrist and flexion at your fingers. So as to do flexion at your wrist or to do flexion at your fingers, what kind of muscles they have to innervate? Okay, so in this scenario there are only one kind of muscles that are affected, not one muscle, one kind of muscle. Okay, okay, all the intrinsic muscles of hand are affected. Okay, so this is the thing that is happening. Now what happens is ki majorly you would say that majorly the C8 and T1 are affected, but sometimes we have also seen that C7 is also affected. C7 but sometimes. Okay, so if you mention C7 in your answer, please write it in bracket and please also write that it is happening sometimes. Now what are the clinical features that you are going to see here? Okay, Okay, so what initially I told you, okay, if one action of a muscle is gone, then the contrary action it is going to become strong. Okay, so first all the intrinsic muscles of the hand are gone. Okay, which means flexor of the wrist and fingers and flexors of the wrist are also gone. Intrinsic muscles of the hands are also gone. Okay, flexor of hand are also affected and intrinsic muscle of hand are also affected. Okay, now your flexors are affected. What do we say? Your flexors are affected. What does that mean? That at your wrist joint, flexion would become harder for you. Okay, so what would happen in that condition? Extension will become strong. Okay, but why is flexors affected? Flexors are affected because they are supplied by C6, C7 and C8. Okay, so in this condition, because of the C8, the flexors of the hand are affected. Okay, and why are intrinsic muscles affected? Because it is simple, because they are innervated by C8 and T1. Okay, so they are affected. Now as these both muscles are affected, okay, they are going to give you a particular typical feature. In case of this what do we say, Erb's palsy, we saw that there was a policeman step hand or potter step hand or waiter step hand. Okay, so what kind of hand we are going to be presented with in case of Klumpke's paralysis? And the answer is, of course, that is claw hand. Okay, you are going to be presented with the claw hand. Now what happens in claw hand, you will tell me. Okay, just comment me what happens in claw hand. Okay, comment what happens in claw hand. Okay, you tell me what happens in claw hand. Remember one thing, there is one ulnar claw hand also. Okay, there is ulnar claw hand also. That is a whole different shit. Okay, that is whole different shit. Okay, do not mix it up here. Okay, that you know, here is claw hand, we have also studied claw hand in ulnar now. Okay, that is different shit. Okay, don't try to mix things up. Okay, this is claw hand. Second would be now your motor function is affected. Contrary, your sensory function will also be affected. Okay, so there will be loss of sensation. Okay, where would be your loss of sensation? It would be along the medial border of forearm and hand. But why along the medial border of forearm and hand? Because this area is this particular area, it is going to be supplied by the T1 nerve. Okay. Now I told you in the Erb's palsy that there is no autonomic signs that we have seen in the Erb's palsy. Okay, but that is not the case with the Erb's palsy. With the Klumpke's paralysis. In Klumpke's paralysis, okay, Horner syndrome is also seen. Okay. In 2-marker question, they might ask you what is Horner syndrome, or in a 10-marker question, if it is related to the brachial plexus, they might ask you in a sub question for 2 marks that what is Horner syndrome. Okay, so you might not want to leave it. Okay, so what is Horner syndrome? It is an autonomic sign. Okay, so in case of Erb's palsy, Klumpke's paralysis, the autonomic sign that we see is Horner syndrome. Now why do we see this autonomic sign? Okay, autonomic sign means either it could be sympathetic, either it could be parasympathetic. So what are the fibers that are affected in this particular Klumpke's paralysis? So we know that T1 is affected. Okay, we know that T1 is affected, but along with T1, sympathetic fibers are also affected. Okay, the sympathetic fibers which we see that supply the head region and the neck region, they leave from the T1 region. Okay, so sympathetic fibers which leave the spinal cord at T1 level are also affected in this particular kind of paralysis. Okay, because of which we suffer an autonomic sign that we address as Horner syndrome. Okay, now what I told you, this sympathetic fiber supplies the head and neck region. So the symptoms which we are going to see right now, they are not going to be associated with your upper limb, they are going to be associated with your face region or your head and neck part. Okay, so what do we see in Horner syndrome? So first which we are going to see is, that is your partial ptosis. Okay, what is partial ptosis? That is a drooping of eyelid. Okay, why does it occur? Does not matter, don't go into that much of detail, just get this thing in your mind first. Okay, don't go in that much in detail and nobody's gonna ask you. Okay, and even this question, Horner syndrome, this is like one credit question, like if you are close to getting 70 marks, then professor might ask you this question to give you 75 marks. Okay, I would not say this is one of the IMPs, but this might earn you some extra credits. Okay, what is partial ptosis? Drooping of eyelid. Okay, what is the meaning of ptosis? That is drooping of eyelid. Okay, second what would occur? That would be meiosis. Okay, what is the meaning of meiosis? In meiosis, meaning of meiosis is your constricted pupil will constrict. Now just try to remember this one thing, your sympathetic fibers are lost. So what is the function of a sympathetic fiber? Fight or flight. In fight or flight, we require more light that is going to in our eyes. Okay, so for so sympathetic fibers, what does sympathetic fiber do to your pupil? They dilate your pupil, but now your sympathetic fibers are gone. Okay, so if your sympathetic fibers are gone, then your parasympathetic system will become more active, because of which what will happen? Constriction of pupil. Okay, this is one of the tricks that you could try. Okay, third there will be anhidrosis. Okay, what is anhidrosis? That there will be no sweat production. Why? Because the sympathetic fibers that were supplying your glands are damaged. Okay, and lastly there would be enophthalmos. Okay, what is enophthalmos? That is a sunken eyeball. What does this mean? That your eyeball has gone back into its orbit. Okay, like it has gone into your orbits. Okay, so I would say this was all about the clinical correlation that was associated with the brachial plexus. Okay, so try to get these things right. Okay, because this brachial plexus portion is like the passing thing. Okay, you at least have to know this. Okay, in vivas, like if you are not able to identify your nerves, okay, in the upper limb hand or upper limb model or something, that is not much of a worry. Okay, the professor might think that you not given attention during the DH. Okay, that is not much of a worry thing, but the questions that he's going to ask you from this brachial plexus, that are of much more worry. Okay, so please prepare this. Okay, and thank you from studying from me. Okay, and please do refer to this to your friends too. Okay.